Welcome back, everyone. If you're staring down the barrel of Pharmacology Exam 4 right now, you already know that cardiac medications can feel like an entirely different language. You're dealing with complex mechanisms, incredibly strict nursing protocols, and side effects that can literally turn a patient's status upside down in a matter of seconds. Well, today's explainer is your ultimate masterclass. We're going to crack the dense code of these cardiac meds together, transforming that massive mountain of data into a highly organized, totally practical toolkit.
Look, I get it. You're probably wondering, how on earth do you memorize dozens of life-saving and potentially life-threatening cardiac medications without absolutely losing your mind? It's overwhelming, right? But I promise you, the secret here isn't rote memorization, it's structure. By grouping these drugs by how they actually act in the body and focusing in on the critical, highly testable safety red flags, we're going to lock this information into your brain for good.
All right, let's dive right into our Cardiac Toolkit blueprint. We've got 6 parts today: relieving angina chest pain, pumping up heart contractility, the adrenergic agonist jolt, taming irregular heart rhythms, breaking down beta blockers, and finally, essential specialty cardiac meds.
Starting off with Part 1, relieving angina chest pain. So when a patient's coronary arteries are spasming or literally starving for oxygen, we need medications that dilate those vessels, and we need them fast. The gold standard here is nitroglycerin, but the administration protocols are incredibly specific to ensure clinical safety. For sublingual tabs, obviously you place it under the tongue. You can give up to 3 tabs total, spacing each one 5 minutes apart. But here's the absolutely critical rule. If there is 0 response after that very first tab, you call 911. Got it? For transdermal patches, you must remember to remove them at night to stop the patient from building up a tolerance. And what about the topical ointment? Well, you apply the ordered dose spread out across 2.5 to 3.5 inches of paper, and you put it on a clean, hairless body part. And please, whatever you do not touch the ointment yourself while administering it, or you're going to be giving yourself a pretty hefty dose.
Now, here is a massive safety warning you absolutely have to remember. You must never ever mix nitroglycerin with erectile dysfunction medications like sildenafil. Why? Because both of these medications cause vasodilation, so combining them creates a severe, life-threatening risk of profound hypotension. Their blood pressure will just tank. This is a huge red flag and a highly testable concept on pretty much any pharmacology exam.
Real quick before we move on from angina, let's talk about ranolazine, which is used for chronic angina. There are quite a few interactions to watch out for here, things like macrolide antibiotics and antifungals, but the really big one to remember for your exams is grapefruit juice. Drinking grapefruit juice actually increases the medication levels in the blood, which can lead to some potentially dangerous adverse effects, like T prolongation and bradycardia.
Moving right along to Part 2, pumping up heart contractility.
When the heart is failing and standard medications just aren't controlling those symptoms, we bring in the cardiac glycosides. The absolute star of the show here is digoxin, or lanoxin. I want you to think of this as the ultimate pump booster. It actually increases the force of the heart's contraction while simultaneously decreasing the heart rate and slowing down the SA node firing. This is great because it gives the ventricles way more time to fill up, drastically improving stroke volume and cardiac output. But because it slows the heart down so much, your primary nursing action is non-negotiable. You absolutely must check the apical pulse before every single dose. If that pulse is less than 60, you hold the medication. On top of that, you've got to closely monitor their potassium, magnesium, and calcium levels. If any of those electrolytes are low, your patient is significantly more likely to become toxic.
So what does that toxicity actually look like in real life? Well, digoxin toxicity has some super specific red flags. Early signs are going to be things like abdominal pain, nausea, vomiting, and anorexia, right alongside that dangerous bradycardia. But the real hallmark symptom you need to look out for is visual changes. Patients will specifically report a yellow-green color distortion, and they might even complain about seeing halos around bright lights. If this happens, your antidote is digoxin immune fab. And if they are severely bradycardic, you'll treat that specific symptom with atropine.
Okay, Part 3, the adrenergic agonist jolt.
Let's shift gears a bit. We're talking emergencies now. These are your catecholamines, the drugs you immediately reach for during shock or cardiac arrest. Let's start with epinephrine, which is basically adrenaline. Just remember that epinephrine gives the body a massive jolt. It does this by stimulating alpha-1 receptors, causing severe vasoconstriction to drive that blood pressure up. At the same time, it stimulates beta-1 receptors in the heart to spike both the heart rate and the contractility. And it hits beta-2 receptors in the lungs to cause bronchodilation. It's truly the ultimate lifesaver during a cardiac arrest or shock scenario. But you have to monitor their vital signs and EKGs incredibly closely because it can very easily trigger dangerous dysrhythmias and severe hypertension.
Next up is norepinephrine, which is another incredibly powerful vasoconstrictor used for life-threatening hypotension. But with norepinephrine, we really need to talk about a severe complication: extravasation. This is when the IV solution literally leaks out of the blood vessel and into the surrounding tissue. Now, this is different from your basic IV infiltration because extravasation causes actual tissue damage. It can even lead to digital necrosis, which is where the patient's fingers and toes turn black as the tissue dies off. It's serious. If extravasation happens, the antidote is an immediate subcutaneous injection of phentolamine directly into the affected area. All right, let's untangle a pair of meds that sound so similar it's practically unfair on an exam. Dopamine and dobutamine. It is so easy to mix these up. Dopamine, at low doses, uniquely dilates renal blood vessels. We use it to treat shock and acute kidney injury, and the way you know it's working is when you see an increased urinary output. Dobutamine, on the flip side, is specifically used for acute heart failure, very often right after a patient has had cardiac surgery. Because of how intensely it impacts cardiac output, a patient on dobutamine is going to require an arterial line so you could precisely monitor their pressures.
Section 4 already. Let's get into taming irregular heart rhythms.
Now we're entering one of the absolute trickiest areas in all of cardiac pharmacology. There are 4 main classes of antiarrhythmics, and class 1 has this massive, intimidating list of drugs. You might be looking at this fast food burger and fries and wondering what on earth it has to do with your pharmacology exam. Well, believe it or not, this actually holds a secret genius mnemonic for memorizing this entire chunk of medications without even breaking a sweat.
Here's how to decode it. For Class 1A, just picture a double quarter pounder that maps perfectly to discyperamide, quinidine, and procainamide. For Class 1B, think of your burger toppings: lettuce, pickles, mayo. That gives you lidocaine, phenytoin, and mexilatine. And finally, for Class 1C, you finish your order with fries, please, which stands for flecainamide and propafenone. Just remember your fast food burger order and boom, you've instantly memorized 8 super complex antiarrhythmias.
Now, let's pivot to Class 3 potassium channel blockers and Class 4 calcium channel blockers, because there are some major warnings here. For Class 3, amiodarone is the big player. It's used to manage life-threatening ventricular dysrhythmias, but it carries a severe risk of pulmonary toxicity. If your patient starts developing a cough or dyspnea, that is a bad sign. You always want to obtain a baseline chest X-ray and pulmonary function test before starting it. For Class 4 calcium channel blockers, like verapamil, diltiazem, and amlodipine, these work by decreasing heart rate and contractility, but watch out for interactions. Mixing a statin with amlodipine increases the risk of muscle breakdown, also known as myopathy. And yep, once again, you've got to avoid that grapefruit juice.
Next up, Part 5, breaking down beta blockers. You probably noticed we totally skipped Class 2 antiarrhythmics a minute ago. Well, that's because beta blockers really need their own spotlight. Let's break down the absolutely critical difference you must understand to safely give these drugs. Beta-1 blockers, like metoprolol, atenolol, and esmolol, affect only the heart. They cause bradycardia and decrease cardiac output, and they carry a black-boxed warning that stopping them abruptly can trigger angina or even an MI. But look closely at the non-selective beta blockers, like propranolol, nadolol, or carvedilol. These affect both the heart and the lungs. Because they can cause bronchoconstriction, you absolutely do not give these to asthma patients. It's a huge risk. Plus, they can mask the warning signs of low blood sugar, so you have to use extreme caution if you're giving them to a diabetic patient.
And finally, Part 6, essential specialty cardiac meds. We've reached the last section of our toolkit. Let's hit a couple of highly specific specialty meds, starting off with the adenosine. When you're administering this to terminate a paroxysmal supraventricular tachycardia, or PSVT, you definitely do not drip this in slowly. I mean, its half-life is incredibly short. The protocol here is extremely strict. You push this medication quickly into the IV, and you immediately flush it right after. It works by dilating the coronary arteries, but be prepared. It can actually cause a brief period of asystole, where the heart literally stops for a second before it resets.
Last but definitely not least, we have sacubitril/valsartan, better known as Entresto. This is an ARNI used for chronic heart failure with a reduced ejection fraction. Patients will take this instead of an ACE inhibitor or an ARB. But here is the highly testable fact you need to write down. If you are transitioning a patient from an ACE inhibitor, like lisinopril, over to Entresto, there has to be a strict 36-hour washout period. If you don't wait those full 36 hours, you drastically increase the patient's risk of developing severe, life-threatening angioedema.
All right, we've officially unpacked the entire toolkit today. But before we wrap up this explainer, I want to test you with a quick clinical scenario. If you were handed an IV of digoxin right this second, Walking into your patient's room, what is the very first thing you must check before you even think about administering it? Think back to our contractility section. If the answer didn't instantly pop into your head, you might want to rewind and review. Mastering these highly specific nursing actions is exactly how you're going to completely conquer your exam. Keep studying smart, trust in your new structured toolkit, and I'll catch you next time.